Greetings and welcome. My name is Walt Culbertson, your faculty for today's discussion, Meaningful Use 2016, Meeting the Health Information Exchange Measure. I am the president and founder of Connecting Healthcare, host and producer of the Medical Update Show, and I have a series of experiences relevant for today's discussion, including once having served as the technical and operations lead and HIE project manager for the Florida Health Information Exchange. Our learning objectives for today includes: what is the 2016 Meaningful Use Health Information Exchange Objective and Measure? What is a transition of care or referral event related to the HIE Objective and Measure? What is an electronic summary of care record which should be communicated during a transition of care or referral event? What are permitted methods of health information exchange to be able to communicate a summary of care record? How to meet the measure. We'll discuss some opportunities for relationship management and other capability that may aid in you being able to meet the measure. And finally, what to do if you can't meet the measure. We'll have some tips and suggestions. The 2016 program requirements are derived from a final rule that CMS passed in October 2015 that modified the requirements for participation in the Electronic Health Record Incentive programs for years 2015 through 2017. We will be referencing this rule in today's discussion. Please note, however, that recently, on October 14, 2016, CMS released the final rule implementing the Medicare Access and CHIP Reauthorization Act of 2015, otherwise more commonly known as MACRA. MACRA will have many implications for CMS quality programs for 2017 and beyond. While the focus of this discussion today are on the 2016 program requirements, we encourage you to visit CMS's new Quality Payment Program website at qpp.cms.gov. And you can also visit Connecting Healthcare, where we will be publishing information on the rules and providing alerts as events happen. How long is the 2016 reporting period? Based on the 2015 through 2017 final rule passed in October 2015, for all returning participants, the EHR reporting period was expected to be a full calendar year from January 1st through December 31st, 2016. For eligible professionals, hospitals, and critical access hospitals that had not successfully demonstrated meaningful use in a prior year, the EHR reporting period is any continuous 90 days between January 1st and December 31st, 2016. However, CMS has proposed to change the EHR reporting period in 2016 for returning participants from the full calendar year 2016 to any continuous 90-day period within 2016. This would essentially align all participants in the EHR incentive program to report and attest on a 90-day period. The language is in a proposed rule for the hospital outpatient prospective payment system and ambulatory surgical center payment system. That final rule is expected in November 2016, and we will keep you posted when it is passed. Now let's take a look at the Health Information Exchange Objective. This is contained in the Eligible Professional Objectives and Measures for 2015, dated October 6, 2015. The Health Information Exchange Objective is number 5 of 10 of the Objectives and Measures for 2015. Based on the final passage of the 2015 through 2017 rule, These objectives and measures also apply to 2016. The Health Information Exchange objective are for eligible professionals, hospitals, and critical access hospitals who transition their patients to another setting of care or provider of care, or refers their patient to another provider of care. Note that if you refer or transition less than 100 patients during the reporting period, you are excluded from this measure. Also note that unlike 2015, the alternate exclusion based on participation stage no longer exists. Everyone is expected to comply with the objective and measure if you are transitioning or referring 100 or more patients during the reporting period. And so the alternate exclusion is not available. If you are transitioning or referring more than 100 patients during the reporting period, you are responsible for using certified technology to create a summary of care record and electronically transmitting that for more than 10% of those transitions and referrals. Now let's look at the Health Information Exchange objective in a little more detail. Again, this applies to eligible professionals, hospitals, and critical access hospitals who transitions their patient to another setting of care or provider of care, or refers their patient to another provider of care. A transition of care is defined as the movement of a patient from one setting of care to another. For example, when a hospital discharges their patient to a rehabilitation facility or a long-term care facility. Referrals are those cases where one provider refers a patient to another, but the referring provider maintains their care of the patient as well. A good example of this is a primary care physician who refers their patient to a specialist or perhaps even a hospital. The key in both of these cases is that if the provider is engaged in 100 or more transitions of care or referrals, they are responsible for creating and sending a summary of care record for at least 10% of those transitions or referrals. And now let's take a closer look at a summary of care record. An electronic summary of care record is a document containing specific patient information created using certified electronic health record technology and electronically communicated using some form of health information exchange. The opportunity is for that exchange to be bidirectional. So in this case, not only a physician sending a summary of care record for a patient transition to the hospital, but the hospital sending back a summary of care record when that patient is discharged and their care is transitioned back to the physician. So, what is in a summary of care record? Based on the criteria for transitions of care, which is defined as transitioning a patient to another care setting, the eligible professional, hospital, or critical access hospital should provide a summary of care record that contains transition of care and referral summary information. So in addition to the common meaningful use data set that should be present in most care settings, such as patient demographic information, medications, care plan, problems, laboratory results, and so forth, for transitions of care, the provider name and office contact information of the referring or transitioning physician should also be included, as well as the reason for the referral if in an ambulatory setting, the encounter diagnosis, the cognitive and functional status, and discharge instructions if an inpatient stay was just completed, as well as immunizations. While the data requirements can look complicated, the good news is there are standards for the creation of the Electronic Transitions of Care document. The Consolidated Clinical Document Architecture, C-CDA, is the standard adopted for electronic health record technology certification for summary of care records. The CDA provides a common architecture, coding, framework, and markup language for the creation of the electronic clinical documents. These can be used to communicate a wide range of health information, including clinical, administrative, and population health. In the final 2015 and 2017 rule, all the required data elements for the C-CDA remained as previously finalized in other meaningful use rules, so you should not be seeing any changes from your vendor regarding the data content of a C-CDA file. C-CDA files are structured as standard XML documents. Leveraging the Extensible Markup Language, or XML, provides great flexibility when communicating information in the standard format structure for the exchange of structured information over the Internet. You can see that the way the files are structured are through a series of tags which delineate the beginning and the end of the data. In this case, you can see a starting tag of title for this particular section, which is vital signs, and then a closing title tag with the /title. That lets the computer know when it's interpreting the data that vital signs will begin with the tag of title and end with the tag of /title. Same thing for the temperature. That is text within this particular section for vital signs. You can see the starting tag of text, the temperature 98.6, and the closing tag for text. Again, this allows computers to follow the start and the end of the data and what's contained between the tags. One of the opportunities in using XML to support summary of care records in the continuity of care document format is that they can not only be interpreted by computers, but rendered as human-readable documents. Here is an example of a XML C-CDA that has been applied with a style sheet so that it can be viewed on the screen or printed. So you're seeing the basic raw file as a visualization minus the tags that are associated with the individual data elements. And lastly, again, the big advantage of using the clinical document architecture is its extensibility. There have been created a series of documents for various healthcare settings. The other thing that's of note is that many of these documents contain data elements or sections of elements that are repeated. So for example, under the continuity of care document, you can see that allergies, medications, problem list, procedures, and results are included. You can also see that under a different document for a different transition of care or setting of care, history and physicals, much of the same data is represented. Allergies, medications, problems list, and so forth. These basically are the core data elements that allow for the interoperability and reusability of the data. Very powerful when it comes to being able to create and communicate all kinds of healthcare information in various healthcare settings. Now that we've looked at the Health Information Exchange objective in some detail, let's study the measure a little more closely. Again, eligible professionals that transitions or refers their patient to another setting of care or a provider of care must use certified electronic health record technology to create a summary of care record and electronically transmit such summary to a receiving provider for more than 10% of transitions of care and referral events. Based on our example earlier, if you transition or refer 100 patients in the reporting period, which looks to be 90 days in 2016, then you are responsible for creating and communicating at least 10 of those transitions of care and referrals electronically. Now let's look at how to electronically transmit a summary of care record. Basically, you are free to use any HIPAA-compliant method that's at your disposal. This includes direct messaging, other forms of secure email, different services provided by Health Information Service Providers or HISP. You could leverage query-based exchange rather than a push of information, or use the services of a third-party HIE. It is important to note that with the passage of the 2015-2017 final rule, you no longer have to launch the message from directly within your certified electronic health record system. This should provide you more flexibility and options with regard to how to communicate the record. However, in terms of interoperability, direct messaging is still the best option for being able to communicate and transmit summary of care information. Direct messaging is a national standard created by the Office of National Coordinator. It allows healthcare stakeholders to securely exchange or push healthcare information using standards to known, trusted recipients over the Internet. It is standards-based, built on secure email communication wrapped around special governance and policies. This is what makes direct email such an important capability in healthcare. Those special policies and governance that allow only authorized users to obtain a direct address and connect to each other. It is simple. It connects healthcare stakeholders through a universal addressing and a simple push of information in any format. It is secure. All messages are highly encrypted and verifiable, and that they have not been tampered with during the travel from one stakeholder to another. It's scalable. It uses the Internet, and unlike other more complicated forms of health information exchange, for example query-based, it is much more simplistic in implementation and in use. It is flexible. It can support any message payload, and that is one of the big opportunities with direct messaging. The messages can be between humans, such as standard email, between humans and a computer, such as an electronic health record system application, or it can be between health information record technologies directly, EHR to EHR. And finally, it is available. All certified electronic health record systems must demonstrate direct messaging capability. In addition to the direct messaging capability that every certified electronic health record technology should possess, there are also many other opportunities for healthcare stakeholders to obtain a direct messaging capability. In addition to hospitals sometimes providing the capability to their community providers, many states have implemented a direct messaging capability as part of their statewide health information exchange effort. In the state of Florida, the direct messaging service was established to be able to allow the national direct standard to be able to use through an online portal. Providers without an electronic health record system, or even those that have one but are not able to access their direct capability, can use and leverage this direct messaging portal. It allows for simple HIPAA-compliant encrypted transmissions of PHI, and any kind of attachment or documentation can be sent using the direct messaging capability provided by the DMS service. This can be used for transitions of care and the meaningful use HIE objective for 2016 as well. One of the documents that can be sent is that electronic summary of care record. More information about the Florida Health Information Exchange portal and how to use the mailbox and obtain one is available at www.florida-hie.net. Just look up and access the direct messaging services pages. So what about faxing? Generally, faxing is not acceptable as it is not in the C-CDA format. In order to meet the HIE Transitions of Care measure, an electronic summary of care document must be transmitted from your practice. So that obviously is not a fax. However, there are limited circumstances where perhaps you could communicate an electronic summary of care document and have the end result be a fax transmission. If you can clearly demonstrate that the transition of care or referral receiver of your electronic summary of care record has no other way to receive it but a fax, then you could take a look at using this alternative. Please note, however, that you must possess very clear documentation that you have a understanding that the provider you're communicating to does not have any other electronic capability. The only way they can receive it is via fax. It cannot be the default approach. But the important thing is that the electronic summary of care document must still leave your door in an electronic format. You could, in this case, send that document to a third-party intermediary who would receive it, translate it into that human-readable format, and then fax it to the receiving provider. But again, this is a very limited circumstances where this measure would apply. It cannot be the default. You cannot use the faxing capability directly from your practice. The electronic document, summary of care record, must still leave your practice in that format. So if you use the services of a third party to translate and send it that last leg of the journey to the other provider's office, that would be acceptable. But again, in limited circumstances. Now that we've looked at the Health Information Exchange objective and measure in some detail, let's talk about other opportunities for meeting the measure. Understanding your referral relationships is critical and the first step towards an electronic future. You can't connect if you don't know who is connected. Knowing your relationships is critical not only for meaningful use, but what is coming, value-based care, the merit incentive payment system under MACRA, and if you are participating as a Medicaid provider, meaningful use stage 3. The opportunity is to outreach to your referral relationships and document the details. Who you spoke with at the other office, the dates and the times of the calls. Make a note of the technology that they have. Document any direct addresses that you find, any other methods of health information exchange in your community, and also document, as importantly, their interest and any work in progress that other practice may be in the process of undertaking, and maybe some dates and times to follow back with those other practices. Absolutely critical for today and tomorrow that you understand the capability of those that you work with and transition your patients and refer them to. Be patient in your relationship outreach and approach. Recognize that in many cases you will be leading the way as you outreach to your community relationships to build your roadmap of electronic connections. Many offices are not well informed and won't immediately understand what you are asking for or what health information exchange is, even among those who have adopted electronic health records. Be prepared to do some education along the way. Leverage the free resources available at connectinghealthcare.com. That is why we do what we do, trying to help in our effort of connecting healthcare. While this can be very time intensive, it is well worth the effort. Knowing the health information technology status of your referral partners will be critical to your success and participation in the shift towards value-based care. In our continuing effort of connecting healthcare, we have established a do-it-yourself HIE relationship roadmap toolkit. Available at Connecting Healthcare's HIE Learning Center, download HIE Success. This will give you some good documents to organize and help you collect your critical roadmap information. Not only the direct messaging addresses you find, but also a presentation of the overview of your relationships, whether you are able to contact them, whether they have an electronic health record system, whether they're participating in the quality programs such as Meaningful Use, using direct messaging, and whether you've tested with them or not. You can also organize those within your relationships that are not connected for future follow-up and document all of this in a very detailed spreadsheet that helps you organize and collect all of the relevant information for your referral partners. And finally, for today's discussion, what to do if you can't meet the measure despite all of your best efforts. Many are reporting difficulties in meeting the HIE measure because they cannot find enough transition of care or referral partners connected. The lack of capability to find those using direct messaging and other HIE is emerging, but it is still not quite there. There is a general lack of awareness and adoption, even among those using certified electronic health record technology. That is why we recommend you engage in HIE Success, do your roadmap, understand your connections, and how those within your referral network have adopted and are capable of health information technology such as HIE. At this time, we are still awaiting direction from CMS whether any specific hardship exemptions will be provided. But we do know that CMS is aware of the general lack of availability in many communities of HIE. So our best recommendation at this point is to document, and document some more so that you can make your case to CMS that you've done everything that you can, but through a lack of infrastructure and community availability, you simply cannot meet the measure. And so this concludes our discussion for today. Meaningful Use 2016, Meeting the HIE Measure. I'm Walt Culbertson. I've been your tour guide for today. We at Connecting Healthcare would love to hear from you. Any questions that you have, any clarifications we can provide, please do contact us. We are available and here to help and to assist the community and you in any way that we can. Thank you again, and we wish you wonderful health, and thank you for all you're doing for your patients.